All right, so we'll get started with the lecture portion. Today we'll be going over anorectal disease. We're going to be doing the second year curriculum, which includes anal fissures, anorectal abscesses, fistula in ano, fecal incontinence, rectal prolapse, and hemorrhoids. Topics not included today, but are on the ABSCITE and in the year one curriculum: rectal cancer, anal cancer, dysplasia, perianal condyloma, appendicitis, and appendiceal neoplasms. So those are topics you'll have to review on your own for the ABSCITE. Starting off with some anatomy, rectal anatomy. The rectum's 12 to 15 centimeters long. It starts usually at the sacral promontory and ends at the levator ani muscle. The proximal 1/3 of the rectum has peritoneum anterior and lateral. The middle 1/3 has peritoneum anterior, and then the distal rectum is extraperitoneal. The two of the main ways you can tell that you're looking at rectum versus colon is that the rectum does not have any epiploic appendages, whereas the colon does. And the rectum also doesn't have any tinea coli, whereas the colon does. And this is because the rectum has a complete layer of outer longitudinal muscle. Anal anatomy, the anal canal's 4 centimeters or about 4 centimeters long. It starts at the levator ani muscle, which is where the rectum ended. So it starts at the levator ani and ends at the anal verge, which is where the skin meets the anal skin meets the perineal skin. And the dentate line's at the midpoint. The dentate line has about 10 to 15 crypts at the base of the anal columns, and these become important later when we talk about anorectal abscesses. The epithelium lining the proximal to the dentate line is simple columnar epithelium, and then below is stratified squamous epithelium. Then there's a transition zone in between those. So again, simple columnar epithelium lining above the dentate line and stratified squamous epithelium below. I wanted to briefly mention the borders of the ischiorectal fossa. This is also important when we talk about anorectal abscesses, which we'll talk about in a little bit. But the ischiorectal fossa is triangular in shape. The inferior border is the skin, and the lateral border is the obturator internus muscle. And the anterior and medial border is the inferior surface of the levator ani. You can get abscesses in the ischiorectal fossa, and then it's also important to note that the left and right ischiorectal fossa do communicate posteriorly above a small portion of external sphincter and extends posterior to attach to the coccyx, and that becomes important later when we talk about horseshoe abscesses. The vascular supply to the rectum, the arterial supply is by 3 different arteries. The most proximal one is the superior rectal artery, which branches or is a branch of the IMA. The middle rectal artery comes from the internal iliac, and then the inferior rectal artery is from the internal pudendal artery. The anal arterial supply comes from the inferior rectal artery, and then some intramural anastomoses from the superior rectal artery. The venous drainage is similar. So the superior rectal vein is, the important thing here is that the superior rectal vein drains into the portal system. Again, the arterial supply was from the IMA, so that does make sense. And then the middle and inferior rectal veins drain into the systemic system. And then lymphatics and innervation. So lymphatics proximal to the dentate line, lymphatic drainage drains into the inferior mesenteric and internal iliac nodes, whereas distal to the dentate line, lymphatics drain into the inguinal nodes. And then innervation wise, proximal to the dentate line is autonomic innervation, and then distal to the dentate line is somatic innervation from the inferior rectal branch of the internal pudendal nerve. And this becomes important later when we talk about internal and external hemorrhoids. So first set of mini review, let's go with team 3.
Hello.
Hi. What are some of the ways, or the 2 ways that you can tell rectum from colon?
So the tinea broadens at the rectum, one way.
Good yeah, good. So I heard it. There's no epiploic appendages, and the tinea coli actually end. The rectum has that fully full 360 degree muscle layer. So there are no tinea in the rectum. What's the type of epithelium lining above the dentate line and below the dentate line?
Above the dentate line is columnar, and below is stratified squamous.
Perfect. And then the blood supply to the superior, middle, and inferior. Let's just go with arterial supply. Blood supply to the superior, middle, and inferior rectum.
The superior is from the IMA, the middle is from the internal iliac, and the inferior is from the pudendal.
Perfect. Good job. Next topic is anal fissures. Anal fissures begin with tears in the anoderm in the distal half of the anal canal, and this triggers a cycle of pain and bleeding. Anal fissures are usually secondary to trauma, so a lot of times the inciting factor is a history of constipation or a lot of diarrhea. It can also happen from anal sex. The vast majority of anal fissures are located in the posterior midline. You can see in females, it's about 90%, in males, it's 99%. So the vast majority of anal fissures are posterior midline. And if you have a patient that has an anal fissure located more laterally, it's sort of you have to really think about other disease processes being the inciting factor. So a lot of times it can be Crohn's disease or other granulomatous diseases, malignancy, HIV, CMV, or syphilis. So really like a lateral placed anal fissure should kind of make you start thinking about other processes. Patients typically present with pain that is exacerbated by defecation and can last for hours afterward. A lot of times the pain is from sphincter spasm, and often a lot of times it can worsen constipation because patients don't even want to attempt defecation. It can also be hematochezia. A lot of times patients will say that they have blood on the tissue paper after they wipe. And then a lot of times the patients will have a tight sphincter on digital rectal exam, which kind of goes into the pathophysiology of anal fissures. Acute fissures are those that typically are less than 6 to 8 weeks old. And these acute fissures, more than chronic fissures, have a good chance of healing with conservative treatment, which we'll go over in a second. And then chronic fissures have some physical exam findings, which is illustrations on the right side of the screen that tell you that it's more chronic. So you can see raised edges on the lateral aspects of the fissure, exposing the white horizontally oriented fibers of the internal sphincter. And then proximal, you can have a hypertrophied anal papilla. And then more distal is a sentinel pile, which is like a external skin tag. For anal fissures, really conservative management is typically what's done as first-line therapy. This includes a high fiber diet and fiber supplements, At the same time, you want to tell patients to drink lots of water with their fiber supplements, because if they're not hydrating, it can actually worsen constipation. And then sitz baths for symptom control. Usually it's a couple of times a day, plus anytime they have a bowel movement. Stool softeners and then topical lidocaine can help with the pain. If this doesn't work or heal the fissure, then next step is usually a medical sphincterotomy. So this is either medication or Botox injection. You'll read about nitroglycerin ointment, which does relax the sphincter muscle, but it does have more side effects, including headaches, dizziness, and hypotension, versus nifedipine or diltiazem creams, which are calcium channel blockers, which also relax the sphincter muscle. So most of the time I've seen nifedipine or diltiazem ointment. And these can be used for up to 2 months. And then the other option is Botox injection into the sphincter, which does provide relaxation for up to 2 to 4 months. And this can be used in conjunction with the diltiazem or nifedipine creams. And Botox has been shown to have a 1-year healing rate for acute fissures of about 65%. Chronic fissures have a slightly lower healing rate with this therapy than acute. There was one statistic I found that had about a 50% healing rate with nifedipine versus about 35% in the placebo group. And really, these are the mainstays of initial treatment. And if these don't heal the fissure, then you move on to surgical sphincterotomy. Surgical options for anal fissures include a lateral internal sphincterotomy, which is really the gold standard of treatment at this time, mostly what I've seen. It's done in the lateral position because you don't want to do a posterior sphincterotomy, which creates a keyhole deformity and has a higher rate of post-incontinence. Fissurectomy can also be performed. This is where you unroof the fissure tract, remove that hypertrophied papilla and external sentinel pile. And really the internal sphincterotomy has a higher healing rate than fissurectomy. And then if the fissure has led to a anal stricture of any kind, then a YV anoplasty can be performed. The lateral internal sphincterotomy is done in either an open or closed technique. The open technique refers to actually incising the anoderm to divide the internal sphincter under direct vision, which is what you'll see on the right-hand side of the screen. The closed technique is where you do not incise the anoderm to directly view the sphincter muscle, and instead a blade is inserted into the anoderm in the inner sphincteric groove, and then the internal sphincter is divided. I think most of the attendings here and what I have seen is the open technique, but I did find a 2010 Cochrane review, which included about 3,500 patients, that didn't find a significant difference in healing or incontinence rates between open and closed approach. So I think it's mostly up to surgeon preference and how they were trained. And then it's important to be careful in patient selection for this procedure because there is a risk of fecal incontinence post-op after this procedure. So if there's any question or preoperatively of your patient having any fecal incontinence, you may not want to offer this procedure. And I found up to 50% of patients undergoing this can have some temporary incontinence to stool, gas, or soiling in the post-op period, but it's lower than that for like long-term. Moving on to anorectal abscesses. So these abscesses develop from an infected anal crypt gland, which again There are about 10 to 15 crypts of Morgagni at the dentate line. The glands penetrate the internal sphincter and end in the intersphincteric plane. And anorectal abscesses account for about 100,000 patient visits to the emergency department in the US each year. Patients typically present with anal pain independent of defecation, which is different from the anal fissure, and is some of the common complaints are swelling and fever. Classification is based on the space that they occupy. So ischiorectal abscesses occur in the ischiorectal space, and they are the most common, accounting for about 60%. Perianal are more superficial, just right below the skin and in the subcutaneous space. That accounts for 20%. Intersphincteric accounts for about 18%. And then supralevator is above the levator ani muscle. That is the most rare and accounts for about 2%. Patients can present with an indurated bulge with fluctuance and cellulitis, kind of like any other abscess near the anal verge. That would be consistent with a perianal abscess. Intersphincteric abscesses, since they're in the intersphincteric space and a little higher, often lack these external findings, but you can cause exquisite tenderness on digital rectal exam. And then ischiorectal abscesses will often have induration, tenderness, and fluctuance a few centimeters away from the anal verge. Management here is typically incision and drainage. Most can be drained cutaneously. And since there is a really high association with fistulae, about 30 to 50% of patients with abscesses will develop fistula. It's important to have that in mind and for counseling of the patients, and also to probe to see if there is a fistula. Typically after drainage, antibiotics aren't necessary, but there are a few patient populations where you should consider sending oral antibiotics. This can be in immunocompromised patients, those with diabetes, if there is cellulitis on the exam, and those with prosthesis, either a valvular joint or intravascular prosthesis. So again, typically, if there isn't really cellulitis and they don't have immunocompromised, you don't typically send with antibiotics. I quickly wanted to just mention as well that there are a couple different populations where you may not do an incision and drainage. One of them is in neutropenic patients. So you'll get consults like this sometimes for patients who are neutropenic. So if they have a neutrophil count less than 500, they actually don't have enough of a response to create any purulence. So those patients are treated with antibiotics, and we usually do not make any incision. There's nothing to drain in that patient population. And then also in infants and pediatric surgery, it's also important to try and treat these expectantly with antibiotics, as there is an increased incidence of iatrogenic fistula creation with incision and drainage. I mentioned horseshoe abscess earlier. This is where the abscess pocket actually communicates on both the ischiorectal space and communicates posteriorly. Horseshoe abscesses are harder to treat. They're often inadequately drained. So this is kind of like one of the treatment paradigms I saw in Cameron's text. So the deep posterior space is probed, and then elliptical counterincisions are made over the ischiorectal fossa on each side, and then a Penrose drain can be left to make sure it's adequately drained. The posterior aspect is also drained. And then if there is an associated fistula, a seton can be placed, which we'll talk about a little bit more in the fistula section. But the seton basically is this vessel loop usually that sits in the fistula tract and helps continue drainage and promotes fibrosis of the tract. And then typically for these horseshoe abscesses, you drain them adequately. And then if there's a fistula, we'll take them back later for repair of the fistula. All right, team 4, let's go with you guys for the next review. What is the most common location of an anal fissure? We can move. Team 4 doesn't seem to have a mic. Oops, giving away the answers. Let's go with team 5.
I think it's Elmhurst's time to shine.
Jesus Christ.
Can you guys hear me? Team 4?
Oh yeah, we can hear you now.
Okay. Sorry, I was trying to figure out how to unmute here. Sorry, so saying the most common location, I also put in the chat, is the posterior midline. Conservative management include sit baths, high fiber diet. You can also do like glutathione cream or nifedipine cream. Alternatively, also Botox or sort of chemodenervation. Sequelae of anorectal abscesses can include.
Well, what's the
Shouting.
you're gonna have to counsel patients on, and then that can form later. That's where I was going with that.
Sorry, could you repeat that?
I was just asking what after an abscess is drained, or even in association with an abscess, like what is the main association with these abscesses and what you have to counsel patients on and deal with later?
Would that be fissure formation incontinence?
It'd be the fistula and ano.
Yeah, anal fissure.
Yeah. Good job. All right, moving on to more detail for fistulae. These are classified, or they are basically an internal opening into the rectum or anal canal, and an external opening on the perianal skin. Typically, patients will either present with drainage, chronic purulent drainage, or have recurrent abscesses. On exam, you can see the external opening, typically like looking like a pustule-like lesion on the external skin. Sometimes you can have a palpable cord if the tract is superficial. Goodsall's rule is the picture in the top right. So posterior fistulas, well, actually, first, Goodsall's rule is where you draw a transverse line across the anus, and then looking at them in lithotomy, posterior is below and then anterior is above. So posterior at 6 o'clock, anterior at 12. And then the rule is that anterior fistulas to this line that you draw typically go to the anterior midline, and they have a straight tract. And then posterior fistulas go, the external opening is posterior. They typically have the internal opening in the posterior midline, so they have this like curved tract instead of a straight tract like the anterior fistulae. Classification of these fistula tracts actually were described first in 1976 by Park. So it's called Park's type 1, 2, 3, and 4. Really, we use the anatomy to describe these. So the most common fistula is an intersphincteric fistula. That's a tract between the two between the two sphincters, so internal and external sphincters. You can have a transsphincteric fistula, which crosses the sphincter complex. You can have a suprasphincteric fistula, which is still opens at the dentate line. So all of these first three types all have an internal opening, typically at the dentate line, corresponding to the glands that we talked about before. So they're cryptoglandular in origin. And the suprasphincteric one is the internal opening at the dentate line, and then the tract actually extends up above the levator ani and then comes down towards the perianal skin. And then extrasphincteric, which is the most rare, is typically not cryptoglandular in origins, usually secondary to trauma of some kind. And it has an internal opening actually above the dentate line and the rectum usually, and then it extends down to the perianal skin. Fistula are typically diagnosed oftentimes on exam with an examiner anesthesia, but MRI has been shown to be pretty sensitive and specific, has a sensitivity of 87% and specificity about 70%. MRI is typically what I've seen be ordered for patients if there's questions about which type of fistula there is, or you wanted to just have preoperative planning. And I often see it in patients with Crohn's if you want to assess for complex fistulae. Endo or ultrasounds also mentioned in text, but I've never really seen it. Typically we get MRI. And then management depends on how much sphincter is involved in the fistula. If there is not a lot of sphincter complex, then you can typically get away with a simple fistulotomy, as there's lower risk of fecal incontinence after that procedure. But the other types of treatment can be a ceton placement, an advancement flap, a lift procedure, which we'll talk about these. So superficial fistulotomy or simple fistulotomy is appropriate for superficial fistula, those that are intersphincteric or low transsphincteric fistula, not involving a lot of the sphincter complex. There's not really like a hard and fast rule, but what I saw was typically if less than 30% of the sphincter is involved, you can usually perform a fistulotomy. This is done by cannulating the fistula tract and then incising the tissue overlying the probe, typically with the electrocautery. The epithelial lining of the tract is fulgurated with a curette or electrocautery to remove debris and granulation tissue, and then the wound is left open to heal by secondary intention. If you end up with a pretty large wound, you can also accelerate healing by marsupializing the wound edges. You can see an example of that on the illustration on the right. And marsupialization refers to the skin and subcutaneous edges being sutured to the base of the wound. Success rate for fistulotomy is generally pretty good and more than 90% success rate at healing. But it does have the highest rate out of the surgical options of fecal incontinence. Ceton placement, I mentioned it a little bit earlier, but there's either, I'm not really going to talk about cutting ceton, but there's non-cutting and cutting. Just to mention it, cutting cetons is where you place the ceton into the tract and then you progressively tighten it. And that kind of performs like a fistulotomy over time. So non-cuttings, and I really don't see that very often, so that's why I didn't go into that, but non-cutting ceton is placing the vessel loop through the fistula tract, and then it's basically tied together on the outside to create this circle of material that goes through the fistula tract. It promotes ongoing drainage of sepsis and promotes fibrosis, maturation, and shrinkage of the abscess cavity over time. The This typically is done to mature the fistula tract, and then typically you take the patients back for a second stage procedure, either a fistulotomy or sphincter preserving operation, which we'll talk a little bit about in a second, usually 6 to 10 weeks later after drainage of an abscess. In patients who have complex fistula, or a lot of times in Crohn's patients, the CTON can just kind of be the definitive procedure, so you just leave them in place. Lift procedures, ligation of intersphincteric fistula tract. This is one of the newer procedures, first described in 2007. It's often performed as the second stage procedure for a transsphincteric fistula. Results in the literature kind of varied, with primary healing rates about 50 to 90%. Impact on continence is generally pretty low. And then some risk factors for failure of this procedure are fistulas that are very proximal or high, because it's hard to dissect out the tract. If the tract is longer than 3 centimeters, if they've had previous fistula surgery, and then obesity has also been associated with failure of this procedure. This is a picture series of this procedure. So A shows just probe through the fistula tract. B has oftentimes the Lone Star retractor can kind of help with exposure. So you make an incision over the anoderm and try and expose the fistula tract. D has the fistula tract kind of splayed open. You ligate and incise that fistula tract and then reapproximate the anoderm, which is kind of like at F. And then F shows injection of hydrogen peroxide to try and establish that the fistula tract is no longer patent after you've ligated it. And then G is the final product. Another technique that can be offered for fistulae that have a lot of sphincter involvement, so you cannot perform a simple fistulotomy, is an anorectal advancement flap. This is where the internal opening is the mark of the apex of the flap, and you really make a flap dissection from distal to proximal, including mucosa, submucosa, and a little bit of the internal sphincter. The proximal end of the flap should be wide to ensure adequate perfusion. The internal opening is closed with suture, and then the tip of the flap's pulled over that internal opening, and then the edges of the flap are reapproximated with suture. This technique has a pretty good success rate, but again, pretty varied in the literature, between 40 and 90%. And then more specifically for cryptoglandular disease, it's a little bit better, 70 to 80 or 70 to 90%. Again, just like the lift procedure, obesity is a risk factor for failure, a history of radiation, and then prior attempts at repair, smoking, and IBD can be risk factors for failure of anorectal advancement flap. And then I was surprised by this because I'm not sure exactly why this technique would worsen continence, but it's about reported in about 35% of patients worsening bowel continence after this procedure. Moving topics to fecal incontinence. So the picture on the right has some of the different mechanisms for how we maintain continence. An intact, properly interconnected and responsive anal sphincter complex, as well as pelvic floor musculature, which is the puborectalis sling, really are the mainstay of providing fecal continence. And then the hemorrhoid cushions add kind of like a little bit of pressure and seal at the end of the anal canal. Urge incontinence is defined as feeling the urge to defecate, but incontinence occurs despite efforts to retain stool. And then passive incontinence is when the patients lack awareness of the need to defecate before the incontinence episode. Etiology can be anal sphincter weakness or dysfunction, decreased perception of rectal sensation, and decreased rectal compliance. It can also just be idiopathic in nature. Some risk factors for fecal incontinence, big one is obstetric trauma, age, diabetes has been associated, and then sphincter trauma and fecal impaction. Workup for these patients focuses on assessing the sphincter integrity and the anorectal function. So these patients can often undergo anal manometry, and then MR defecography is helpful in assessing predominantly pelvic organ instability. And then it's important to have endoscopy to rule out mucosal inflammation or masses causing this. Initial management, again, is usually conservative in nature. So food diaries, bulking agents, antidiarrheals, and then manual disimpaction when indicated if there's stool impaction. Patients often undergo biofeedback training if the manometry on the workup shows weakness of the external sphincter or decreased ability to perceive rectal distension. Surgical management is typically for those that still have fecal incontinence after biofeedback training and initial conservative management. And this includes a sphincteroplasty, sacral nerve stimulator, and then in really severe cases, can consider fecal diversion. This is just a table out of Cameron's for the different types of options available with the goal of what you're treating with those options. So again, we're going to be talking about sphincteroplasty for defects in the sphincter. The sacral nerve stimulator is really important and kind of like the mainstay of surgical treatment now, which enhances an impaired sphincter function. And then again, I'm not going to talk about this in detail, but you can consider fecal diversion. So a sphincteroplasty typically performed for a defect in the sphincter complex. Again, risk factors for this are obstetric trauma, anorectal surgeries, and anal trauma. The aim of this is to reconstruct the circular configuration of the muscle around the anal canal, and typically done for patients with a defect between 60 to 180 degrees. So if it's larger than that, typically this isn't performed. Short-term results following anterior sphincteroplasty are pretty good with improved continence, about 75 to 86%. But the problem is this response really deteriorates over time with less than 50% of patients remaining continent at 5 to 10 years. The sacral nerve stim, you'll see it here, performed here. It's evolved into the treatment of choice for fecal incontinence. And it provides low voltage stimulation of the sacral nerve roots. It's done in 2 different stages. So the first stage is referred to as a trial phase. And this is where you place the wire with leads into the S3 foramen, usually under fluoroscopy, to confirm that you're in the right space. And then it's connected to an external stimulator. And then symptoms are tracked for 2 weeks. Typically, patients keep like diarrhea, and they track their incontinence episodes. And if there's a greater than 50% reduction in fecal incontinence during this 2-week trial period, then they move on to the stage 2 procedure, which is where a permanent device is implanted in the soft tissue tissue of the buttocks just below the iliac crest. It is associated with pretty good outcomes, so greater than 50% improvement in incontinence episodes in the majority of patients, about 86%, with nearly perfect control in about 40% of patients. So team 5, I'm going to answer these review questions. So can you tell me the 4 different types of anal fistula according to the Park classification?
You guys hear us? So there's type 1, which is intersphincter. Type 2, which is, I think it's transsphincteric. Type 3 is, well, type 4 is suprasphincteric, but encompasses early. I don't know what type 3 is.
You did intersphincteric, transsphincteric, supra, and then there's one that doesn't involve it at all.
Supra and extra.
Good. And then what's the treatment choice for a very superficial intersphincteric fistula? And that doesn't include much of the sphincter complex.
Superficial on me, right?
I'm sorry, I didn't hear you. If you
A fistulotomy.
good, yeah. All right, moving on to rectal prolapse. So a rectal prolapse occurs when the rectal wall intussuscepts through the anus. It's pretty rare, occurring approximately in 0.5% of the population. Typically, it occurs in women in the 5th to 8th decades of life. If it occurs younger than that, it's usually in association with psychiatric illness, developmental delay, or autism, which I think is more so associated with severe constipation. Historically, multiparity was thought to contribute to the pathogenesis, but about 30% of women with rectal prolapse are nulliparous, so there seems to be some other etiology other than just multiparity. Symptoms can be rectal pressure or pain resulting from the prolapsed tissue. They can experience drainage of mucus or blood from the fibril mucosa. And constipation can also occur secondary to mechanical blockage of the rectum. Subsequent, if prolapse is chronic, there can be subsequent atrophy of the external anal sphincter. Diagnosis is made on exam. Full thickness protrusion may be intermittent, but can be provoked with Valsalva. And then really the hallmark sign of rectal prolapse versus hemorrhoids, which oftentimes get confused, is that the rectal prolapse has concentric rings of rectum protruding through. So that's really an important hallmark sign. Risk factors include age, multiparity, female sex, COPD, and chronic straining or diarrhea. It's important to try and reduce the prolapse. This can be aided by putting sugar or artificial sweetener onto the prolapse. It draws out some of the edema, so you can reduce the prolapse. Again, conservative management is just trying to reduce constipation. So stool softeners, hydration, and sitz baths for symptom control. Definitive management for rectal prolapse is surgical, and there's 2 different approaches. So those that can undergo more intensive surgery or quote, a good surgical candidate, undergo abdominal approaches. And this is a rectopexy, or typically a rectal mobilization and a rectopexy. You can perform a sigmoidectomy at the same time for those with a history of constipation, but I don't really know how often that's truly done. I just saw it more so in like the textbooks that if there's a history of constipation, that sigmoidectomy may also be appropriate at the same time. And then for those that are poor surgical candidates, so those that have a lot of medical comorbidities or are elderly, these patients typically undergo a perineal approach, which is either an Altmaier, which is the procedure done mostly in the United States in adults, or a Delorme procedure, which I'll talk about in a second, which is a mucosal sleeve resection, whereas the Altmaier is a rectosigmoidectomy via perineal approach. But I think for the ab site, really the important thing to note is that if the patient is a good surgical candidate, the outcomes are better for abdominal approaches. So that's typically what you'll want to offer. And then if the patient's unable to undergo an abdominal approach, then you typically will do perineal approach surgery. The Delorme procedure, I wanted to just mention it. So we'll see that Altmaier is done more in the US. Delorme's are performed more in Europe, but I did want to mention it as well because it's performed more frequently also in the pediatric population. So it's done by prolapsing out the rectum as completely as you can to identify the proximal extent of your planned mucosal resection. That's usually done with atraumatic clamps, like an Alice, for example. Then tumescent solution, which is saline and epinephrines injected between the submucosa and the muscularis propria to give you a plane of, and then the mucosa is released from the muscle above the line. Can you see my slides again?
Yes.
So the plicating sutures are done in the circumferential linear array. You tie them, it reduces the prolapse, and then you can suture on the inside to do an anastomosis there, and which is the last two pictures. Outcomes for perineal versus transabdominal repair. So you can see the recurrence rates for the abdominal procedures are much lower, about ranging from 2 to 10%. At the highest would be 10%. There is a slightly higher rate of complications with the abdominal approach, and then the recurrence rates for the perineal approaches are higher, ranging from 10 to about 30%, but have a lower complication profile. So this kind of fits with the patients that you'd be offering. So lower recurrence rates with a little bit higher complications would be appropriate for someone who can undergo that procedure. And then the perineal resections have a higher recurrence rate, but you kind of accept that for a patient who cannot undergo the abdominal procedure. Let's see, Serge Onk. Are you there? Can you answer these review questions?
Hi.
What is the hallmark sign on exam that you can see with rectal prolapse? Like, how would you distinguish it from prolapsed hemorrhoids, for example?
Yeah, seeing the circumferential mucosa.
Perfect. Yep, the circumferential rings. What would be the preferred surgical approach for a poor surgical candidate with a rectal prolapse?
Altmaier procedure.
Good. So more generally, like a perineal approach. And then when would you consider offering a sigmoidectomy at the time of rectopexy for an abdominal approach?
If they have redundant sigmoid.
Um, so it's more so if they've got a concomitant history of constipation, but they probably do have a redundant sigmoid if they have that history. All right, moving on, I think to the last topic, hemorrhoids. So hemorrhoids are normal vascular structures in the anal canal arising from arteriovenous connections, and they drain into the superior and inferior hemorrhoidal veins. Like we mentioned before, they actually do aid in continence and they act as a plug. Internal hemorrhoids are located proximal to the dentate line, whereas external are distal to the dentate line. And you can have a mixed picture as well, extending from both proximal and distal. Internal hemorrhoids arise from the superior hemorrhoidal plexus. There's 3 areas. There's the left lateral plexus, right anterior, and right posterior plexus. So these would be the areas you can look for to see if they have internal hemorrhoids. The overlying epithelium for internal hemorrhoids are viscerally innervated, so they are insensate to pain, touch, and temperature, whereas external hemorrhoids are innervated by the somatic system, so these can be very, very, very painful. Hemorrhoids are classified internal hemorrhoids are classified into 4 different types, whereas external hemorrhoids don't have a classification system. So internal hemorrhoids grade 1 are those that are visualized on anoscopy, and there is no hemorrhoidal prolapse below the dentate line. Grade 2 are those that prolapse out of the anal canal with defecation or with straining, but will reduce spontaneously. So that's the key for grade 2, is that they spontaneously reduce. Grade 3 are those that prolapse, but and do not spontaneously reduce, and they actually require manual reduction. And then grade 4 are irreducible hemorrhoid, irreducible internal hemorrhoids that have prolapsed out. 40% of people with hemorrhoids are actually asymptomatic, but if they do become symptomatic, it's usually perianal pruritus, hematochezia. There can be pain associated with thrombosed hemorrhoids, pain associated with prolapse hemorrhoids, and they can actually have fecal soilage. Risk factors and hemorrhoids are associated with advanced age, pregnancy, chronic diarrhea, chronic constipation, straining, and then prolonged sitting. Thrombosis presents with pain and a palpable perianal lump. Thrombosis is more common with external hemorrhoids than internal hemorrhoids. And then external hemorrhoids are associated with excruciating pain overlying the skin, as again, it's somatically innervated. And then internal hemorrhoids also can cause pain, but usually to a lesser degree when they are prolapse, strangulated, or have any gangrenous changes from strangulation. The mainstay of grade 1 and 2 hemorrhoids are conservative treatment. So this, again, theme of the talk is high fiber foods, fiber supplements, stool softeners, a lot of water, and sitz baths. It's also important to counsel patients to minimize their time sitting on the toilet, to go to the bathroom, and to avoid prolonged sitting if possible, and then to avoid medications that cause constipation or diarrhea. Topical lidocaine can be used for symptom control, as well as hydrocortisone. And then topical nitrates can also be used to relieve the sphincter spasm. If patients are still symptomatic after initial conservative treatment, really the next step for hemorrhoid treatment is our office-based procedures. So these all typically cause sloughing of excess hemorrhoidal tissue. Healing and scarring then fixes the remaining tissue to the underlying muscular ring. Rubber band ligation is really the mainstay here. So it's the most effective and requires fewer treatment sessions than some of the other office-based procedures, and is typically used for grades 1 through 3. There was a Cochrane review looking at 3 randomized trials of surgical hemorrhoidectomy versus rubber band ligation, and to no surprise, surgery versus the rubber band was associated with more pain and more complications. Other office-based procedures that can be performed other than rubber band ligation is sclerotherapy. So this is where you inject the hemorrhoidal tissue with a sclerosing agent, which causes intense inflammatory reaction and scarring. This I've kind of found was indicated, or maybe the only indication is you can still do this procedure on patients who are on anticoagulation or on antiplatelet therapy, whereas you can't really do surgery and you can't do rubber band ligation. And then there's also infrared coagulation, which is a picture on the bottom of the right screen where you use this infrared device that causes protein coagulation and then again an inflammatory response in the hemorrhoidal bed. Surgery is offered to those patients who do not respond to non-op management or office-based procedures, or typically offered for hemorrhoids that are grade 3 or 4. There's a conventional type of hemorrhoidectomy, which is, I'm sure most of you have seen, which is excision, a surgical excision of the hemorrhoid tissue, usually with a knife, and ligation of the hemorrhoid bed, and then you close the wound. That's typically what's done here in the US, called a close or Ferguson type hemorrhoidectomy. There is an open type where you just leave the wound completely open, which does have a lower chance of infection, but it takes a lot longer for the wound to heal. So that's not really done often here. And then there's also a stapled hemorrhoidectomy, which is done with an EEA type stapler, which is, you can see pictures on the bottom of the right screen. This is only done for internal disease, whereas conventional hemorrhoidectomy can also be done for external. And then stapled hemorrhoidectomy has been associated with less pain than the conventional type, but overall does have increased rates of incontinence, tenesmus, and recurrence in the long term than conventional hemorrhoidectomy. So typically it's not the first line. Hemorrhoidectomy is it's very painful surgery and can be pretty bloody. We often counsel patients that they're going to have pretty bad post-op pain after hemorrhoidectomy. Some of the complications can be hemorrhage, infection, urinary retention, and fecal impaction are kind of secondary to the pain from the surgery. There can be anal stricture as a complication, and then you can also injure the sphincter during the surgery. I think this may be the last review, so Elmhurst, take this one away.
Left lateral, so right anterior and right posterior.
Good.
Banding.
Good.
We just talked about this.
Oh, and then I didn't actually mention this. I forgot to mention.
72 hours.
Trick question. Yeah, so in thrombosed hemorrhoids, there's this threshold you see in a lot of the textbooks of 72 hours. So less, if a patient's had pain for less than 72 hours, then you can consider draining the thrombosed hemorrhoid, which will cause symptom relief. But really, after 72 hours, it's deemed kind of like not worth doing the drainage at that point because it's going to resolve soon. Good job. All right, we're going to go rapid fire. Just have some like 5 or 6 pictures of different types of anorectal pathology, and I just want you to say like what the diagnosis is. So surgery library. Well, what am I looking at? Do you not? Good, an external hemorrhoid. Team 3.
Abscess?
It's a good guess. It's similar to the previous one. It just has like a little bit.
Thrombosed external hemorrhoid.
It's still an external hemorrhoid, but it's a thrombosed one. You can see like it's a little bit more angry and purple than that one. Team 4. It's kind of a two.
Are we looking like a perineal abscess? Or is it actually just internal hemorrhoid?
Good. So the kind of like that red mucosa is a prolapsed internal hemorrhoid, and then to the right of it, on like a screen right, is actually just an external hemorrhoid as well there. But you can see the difference between the mucosa of like a prolapsed internal hemorrhoid versus the external hemorrhoid. Team 5. I'm sorry for these pictures.
I think it's a mixed hemorrhoid.
It's a good guess. It's all of these are actually prolapsed. These are like grade 4 internal hemorrhoids that are all prolapsed. The one in the middle just has some like irritation, so it's a little bit more red, but they all have that like internal proximal to the dentate like line type of mucosa. Team or surgeon.
Prolapse.
Good. So this is rectal prolapse, which you can see the difference between that and the hemorrhoids. And then Elmhurst, and then we're done.
Fistula.
Fistula. Good. All right, so let's all take a 10-minute break, and then we'll go to the journal club, and then we'll be done.